Anyway, as I said, my earlier presentation was in my role as European Midwives Association President, but this is purely as me as a midwife in UK and how we practice. And there are other presentations in detail about home birth in the program, so I'm going again, just going to give you a very much an overview of models of care that currently are done in UK on maternity. Now, interestingly, when I travel around and I visit different countries, it's quite apparent that most of the people talk about UK as England. So I just wanted to make sure that people understand the UK actually is 4 countries. It's Wales, Northern Ireland, Scotland and England. And they do have their own governments and they also produce their own policies. So it's very important for associations like Royal College of Midwives as a professional organisation, as well as the Royal College of Obstetricians and Gynecologists, to make sure that we try to harmonise those policies and try to make sure that we have the same philosophy of care after women in all countries. And that does happen, especially Royal College of Midwives actually started in 1881 as a midwives institute, and what it really meant was that it was trying to make sure that the midwives that were undertaking births weren't just lay people, they were actually trained. A lot in a sort of health and hygiene more than anything else, and then also a theory, because then they didn't have really midwifery science. And RCM has got boards in all countries, and we are sort of the hub of the profession. So we definitely make sure that we have an input on those different policies. And also RCM is very highly committed to making maternity services that truly meets women's needs and the baby's needs during pregnancy, labour and postnatal period. And it also makes sure that it's very woman-centred. There is something we have learned. I told you a professional organisation and also a trade union addressing research and education, which is about midwives. We must make sure that one of our goals is actually being women-centred when we look at that. So a little bit about UK then. All the maternity services in UK as such, except for some private practices, are provided by the public health service system, which is free on access or point of contact to everybody. So all the women are provided free maternity care, including any intervention or screening. A number of births in UK is 812,970 births in 2012. So there's quite a lot of babies. And actually we find that we have a real baby boom. And in some areas the birth rate has actually gone up 25%. So it has, as I earlier said, it's sometimes a little bit of a challenge when you're planning your services. And if you then look at the England and Wales, the birth rate is about 7,250 anyway. And now caesarean section rate is around 25%, 24.8 on one of the yearly figures. So unfortunately, we do think obstetricians and midwives agree that it's still a bit too high. It should be lower across the 3-4 countries. Our maternal mortality rate is 4.67 per 100,000, neonatal 3.4 per 1,000. And our stillbirth rate is 4.9 per 1,000 total births. And in a minute I'm going to talk about the maternity pathway, but I just wanted to already put in here that it starts very much as a midwife, the first point of contact, and currently 63% of women are put by 12 midwives. That is the aim. Now maternity policies in the UK, it's like every country. I just had an opportunity to have a short discussion about your maternity services. And every country goes through a period of changes. And I think we all agree in the UK that our period of change was sort of between 1990 to 2010. And also the last 3 years it's moved on slightly differently to about family and that. But that was the time when women started to ask, when they came into maternity care and when they were having their babies, they started to ask, why do I have to have that episiotomy? Why can't I walk around? Why can't I do that? And actually enough of women started to ask that. You just couldn't just say, well, that's how it is, you know, this is what we do in the hospital. You actually started to work more and more with the women. And also, at the same time, the midwives were changing. The midwives were wanting something more from their profession. And they were saying, well, look, you know, I can do this. So why is it that when a woman enters, and that was actually sort of on the 80s already, but when a woman enters the labor ward, you know, I examine and everything else, but if I think she's not in labor, I might have to ask in some units the doctor to say that she can go home. I can do that. And there's no difference. I'm autonomous, I know how to diagnose labor, I should be able to do this job. So there was change in there. And the societal changes with the women, they're very much that women now have careers, they had opinions, they had much more organized life, they were starting to have their babies late, so they were very opinionated. And all together, with midwives, with women, because I always believe that midwives alone cannot change the world. We have to work with women because they are the biggest numbers and they are also the biggest cost. But also with the obstetrician. We looked at the maternity policies and they all changed. And choice became the issue. Choice became the key word about this woman-centered care. So the maternity policy in 1993, I just want to put this up here because I think it was monumental in the change of UK. That's when midwives became that they could say they were lead named professional for low-risk women. And that was more. And that changing childbirth policy by the government supported choice, continuity and control. And that was about women. And also, it recognized then on that they were different environments that we should be able to provide care for women. It would be birth centers, midwifery-led units, and home births. So it was very much of thinking about hospitals and community. And these policies that have come later on have all focused on the same principles. But also, we wanted to make sure that we would have a care that covered all the women, because not every woman is going to be low risk. Not every woman who comes to maternity, especially now, is going to be having good health. They may have some existing conditions that need very much of a more complex care during the pregnancy. So what we wanted to always say that we wanted to have a right person doing the right thing at the right time in the right place. So that would include everybody. If it's obstetrician, if it's a midwife, if it's a pediatrician, if it's a medical diabetologist or somebody. We wanted to have that right person to make safe quality care. But also that really sort of stamped, of course personally from my point of view, that stamped the strengthening of the value of a midwife in that team. And also that she could quite appropriately and autonomously look after low-risk women. So this is our pathway. And again, it's quite a busy chart. I'm not sure, it hasn't been translated maybe, so I'm not sure if you can follow it. But if you look at the pregnant woman, as I said, these policies say the woman actually herself can choose when she finds out that she's pregnant. And we do find that most of the women already come to us and say, I'm pregnant, because they have done their own pregnancy test. When 25 years ago I was doing the pregnancy test, women came to me and said, I'm not quite sure if I'm pregnant, and I will do the test. Nowadays women do the test, come in and say, I'm pregnant. So she will decide if she knows where to find her midwife, or she'll go to her midwife. And if she's bought a pregnancy test, that pregnancy test often in a pharmacist, chemist, will have actually a little note saying where your local midwife is. So you will have a contact number where you can contact your midwife. And that was our campaign to make sure that women would book in early. Or she could go to family doctor, GP. From that on, within 6 to 8 weeks pregnancy, needs assessment. And that would basically, this is this one. And that would basically look at already, if this woman has some other needs, as I mentioned earlier, maybe she's got cardiac condition, and she would need a very early referral to make an assessment of her. From the booking, and that's always a midwife who does it, she does the risk and needs assessment. Then she does a full booking of medical history, what we all do, you know that. And then the decision is made that either she will have midwifery care or she will have maternity team care, and that would mean that she would have also obstetrician involved in some kind of pregnancy, all the time, if necessary. And all through her pregnancy, there might be changes. Something may happen, her blood pressure creeps up, and she's referred to an obstetrician for full assessment, and a plan is made. And if everything settles within that plan, then the obstetrician is happy. The woman can come back to the midwifery care. Otherwise, it would have shared the care all through the time. And then, at birth, as I said previously, you will have choice of having a baby at home. You would have a midwifery care, a midwifery unit, and birth center, if I understood the previous presentation, we were talking about your midwifery unit. And also either midwifery care in a hospital or maternity care in the hospital. So even in the hospitals, midwives will lead the care and they're able to look after the lower children. And then postnatally, as I said, we actually look after women up to 28 days, and it usually as a whole. The women leave the hospital after normal birth anything between 6 to 24 hours. And we find that our cesarean sections now stay about 3 days. So there's quite a lot of need for postnatal care to help women with breastfeeding. And this area, the postnatal care, is our major concern at the moment. Because when any resources are needed with this raising birth rate, midwives are pulled from the community to fill in birth and labour care, and the postnatal care is suffering. So just to mention that within all of these also, we were quite clear, and we have had different models of care for vulnerable women. So if it's a targeting teenagers, drug misusers, obese women, anything like that, sometimes we have specific team that cares for them to make sure that it would be equality for all the women, but also equity of access to women. And we have quite a large amount of asylum seekers and immigrants in cities like Manchester, Birmingham and London. And we do find that because the way they have to move from accommodation to accommodation, it's quite difficult to follow them. Okay, I can hear myself very clearly. I was thinking that I was shouting. And as I said, the choice of places as it is. So we have a very clear national framework where midwives play a central role in ensuring that women have a safe and life-changing experience during their maternity care. And they have the best possible start in life. And this is sort of the move on into talking about including much more the fathers and the families in the care. It also increased the public health role of a midwife, and we are very aware that women, public health issues like obesity, breastfeeding, smoking, alcohol misuse is very much on opportunity for midwives to take the public health role, because often it's the first time when an adult young woman is having a one-to-one direct contact with a health professional. And also we have a principle which is government supported, and I think that you should campaign for this, and I hope I will hear one day that you have, which is one-to-one care in labour. And it actually is spelled out that every woman who is in active labour should have one midwife looking after her. Okay? So that midwife is not going to run between 5 rooms, she's actually concentrating on that woman if she's in active labour. Of course, if you're at the home birth, it's never a problem. But also to make sure that we have appropriate care, and we need to work in teams because we have women that do have other requirements and needs. We are also supporting the obstetricians having 24-hour presence in the labour ward. Because because they felt that the outcomes were better if there was a senior obstetrician or consultant present in the labor ward. So on a national level, again, we have a lot of frameworks that we all stick to. And one of them, some of you may have heard, and these are available on over the web. I haven't put any references because I think it makes it quite heavy going, but anybody can ask me up. We have a National Institute of Clinical Excellence that sets out clinical guidelines. And there's always a multidisciplinary group involving all the professions when these are developed. Sometimes we agree with them and we do in every unit the same thing. And on some level, some units have adaptations. But also what they have done now, they have set quality standards. And that's very much agreed that everybody should have that standard as an outcome of care. And also we are supported with research. I mean, we had a really big research for 5,000 births. It was looked over a 5-year period of births. And we looked at the different outcomes from a different place of birth. So we compared home, birth center, and hospital unit for low-risk women. And it actually was found that there was no difference on the outcomes, the safety on the outcomes on the birth center and the hospital birth. There was slightly increased risk on the neonatal outcome on the home birth for the first baby, not on the second one. And also we are working on trying to find out what other things that we can extract from the study so we can look that the care is appropriate. But it was very much like that on your presentation, that it was about positive outcomes. There was much less of intervention on midwifery-led units. There was much lower rate of cesarean sections in some of the areas. But that wasn't really the main thing. But certainly it was very positive as regarding how women undertook a physiological labor. And of course we got this sort of worldwide Cochrane reviews about midwifery-led care that was just published this year, which very highly, again, highlighted the same issues about better outcomes. And this is just, actually it is in English, so it doesn't really make. I just wanted to pick 3 issues out of the antenatal quality standards that all the services have to work through. There's 12 of them all together. And the first one is basically about early access. Let's get the woman hooked in, let's plan the care and have regular checkups all through the pregnancy. And also that not only in labor we advocate one-to-one care, but also that every woman should have a named midwife that she knows that she can contact if she's concerned. So every woman in UK should have a named midwife that she can contact. And also that we very much involve our women so they carry their own notes. And sometimes some women actually enter issues into the notes. And these are sort of in very snapshot the models of care that deliver this type of care. So first of all, we have midwifery-led care provided by team midwives. It's usually about 6 midwives. They provide continuity of care. The women will meet all the midwives during her antenatal period, because it may be that if she goes into labor in the night, we have an on-call system, and it might be that my women are not on call that night. So one of my team, my partner, will look after her. So that's the first type of care. But the woman will have met the midwife in the team during her pregnancy. Then we have much more sort of concise caseload midwifery, which is that some midwives in their time of life are able to do 24-hour care 7 days a week. And they usually do like blocks of 3 months that they are on call, they are working 24 hours, 7 days for 3 months, and then they have a long period of time off, maybe a month, and then another 3 months. So that takes a lot of commitment. But those midwives would have, they have the same salary, but they would have about 35 women each. And again, they will cover the holiday period. And these caseload midwifery models have very high home birth rates, because the women don't really decide where they're going to give birth. These are all low-risk women and they will decide then when they go into labor at home, if they transfer to the hospital because it suits them, they have other children at home, that's what they will do. And if they decide to stay at home, we are happy so. And it is under NHS, this is not private, independent midwifery, it's an NHS model. And then of course we have a home birth. And this is one of the women, a traveler, so it's a tent, because a lot of they're not like a Romanis, maybe Central European, but they're Irish travelers, and they have all kind of different type of caravans. And I knew this midwife, and it was an opportunity to take a picture. So normally you would have a bedroom, but I just thought that was really interesting with her lovely stove and pots of tea for the midwife while you were delivering. And then we do have some independent midwives, as I mentioned, and these midwives are employed directly by the midwife, by the women. So the women have to pay for this care. And the midwives will have links with the hospital, because if there's a problem, they still need to transfer or refer the woman to a hospital. But these midwives occasionally, for example, breech delivery or breech birth, it's changing now, but we went through after the HANA trial, we went through a period when breech really everybody said it's cesarean section, it's a cesarean section. And some women felt that they wanted to have a breech, and it does make it quite complicated. And often they referred to home, those women went to the independent midwives because they felt they had more skill and they had more support from them. But we have an issue with the EU Cross-Border Healthcare Directive. In future, actually from October, every health professional providing direct care to a patient has to have indemnity insurance. And these midwives were working without insurance. They told that they have no insurance. But now, by the law, they are not legal, so they can't actually work. So a lot of them have been trying to make a cooperative, which they could maybe link to NHS, but that's a big problem. And then, of course, team-based care, which I would say a lot of women will have team-based care because of the complexities of the pregnancy. And this will be a team health professional led by the consultant obstetrician, so it's quite clearly on the notes who is the lead professional. If low risk is a midwife, if it's anything that needs extra attention and a team approach, it will be consultant obstetrician. We do involve other specialists, as I said, cardiologists, if they cardiologist. This case may be hospital-based, there may be occasional antenatal care clinic in the community, but most of the visit might be in the hospital. And majority of these women, by the reason why they are in team care, will actually give birth in the hospital. But the postnatal care is always taken, but they will continue at the home. And a little bit about birth centers. This is something I've been very, very involved with as trying to make sure that we have a quality standards for that. We have approximately 110 birth centers at the moment in England. And I don't know what is happening to you, but what is happening in UK, that many of, if in an area you have 3 hospitals having about 3,000 births, 4,000 per, and a 3,000 per, now there's a drive to join those units to one main hospital with 10,000 births and very complex cases and having a very intensive neonatal unit. So it has forced the other hospitals of actually thinking about options of becoming a midwifery-led unit. So we do see in the future that there might be increase on these numbers. And what they do, in these units, you provide care for low-risk women, healthy pregnancies basically. Risk is always a difficult topic. And also, it's not just about birth. The units are utilized for antenatal care and postnatal care too. So it's sort of an additional alternative environment for women, especially if they do feel very unsettled and anxious in a very clinical hospital environment. And also, most of the women, when you look at user surveys, say the best thing about home births and birth centers is actually the control. They feel that they are in control of their birth more than anywhere else. You can see in this picture and it's very common. Most of the units that are birth centers, they will have a pool, water birth, and it's very much used during the labor. Not every woman will birth in the water, but it's her choice. She will either just use it for pain relief, or she will actually decide that she will stay there and have a water birth. Some units have 65% water births, and most of the units have 85% women choosing to use the water for pain relief in their labor. And these units may be completely standing alone, away from the main obstetric unit, or they may be alongside in the same building. It could be even next to the obstetric unit. It doesn't always work so well because the logistics in labor ward is busy. Somebody said, "Oh, she just convinced there's a bed in the birth center." But you see, it's not the right type of woman labor. If she has a problem, she's not in the right place if she's in a birth center because the philosophy is different. Or it could be that they're in a building, but they are too close up or down the corridor or something like that. So it's very sort of relaxed environment. We try to support the physiological process of labor, and the midwives are very skilled at doing on that. And also that, as I said, women find it very satisfying and having very individualized care. And what it has meant as an adult, that the people working in a busy obstetric unit have more time and more appropriate team approach for the women that are requiring care there. And in some units they still have no risk rules actually in obstetric. So as I said, we are a professional organization. So we try to make sure that we produce also publications and resources that help midwives to undertake their full role. So, and one of the issues was that people always said, well, the birth centers are not so good. We were talking about, I suppose you use the same clinical governance, about safety and that. So they just thought that midwives would decide, oh, isn't it a good idea to have a birth center? Let's just open a room here and call it birth center. It isn't like that. The college took upon themselves that we produced birth center standards in England, which are quite clearly set out what your standards should be nationally. And then we also produced the second one, the orange one, which is like a birth center toolkit, and that will sort of help midwives to go through the process of setting a birth center. What do you need to consider? All the political drive that you need, the finances, the workforce, the on-call rotas, all that kind of thing. It's sort of step by step to how to set up a center. And also we produce midwifery labor guidelines to make sure that the practice of midwives undertaking this any labor area actually are embedded in the evidence space. So on conclusion, actually I must have missed a slide there because I did want to, sorry, I'm just going back here. I think on this I did not mention on that. Not only that us, the college, we address issues that are midwives, but on the right-hand side you, for example, have a publication that is by the four colleges, by the Royal College of Obstetricians, Royal College of Anaesthetists, and Royal College of Pediatrics and Child Health and Midwifery. We have a lot of national level documents where we sit around the table and we make decisions about this delivery of care. And this one very much addresses about, like I said, about the presence of the consultant in the labour ward, what his role is, about the roles of the midwives, what type of midwives should be in the labour ward, and also the numbers and etc. So it's really important that it's not only just us doing something in an isolation. Of course, birth centers are a midwifery area. There was an obstetrician involved, but it wasn't there because it wasn't a multidisciplinary area. So we encouraged all the medical students to have experience in the birth center. So on conclusion, I think I need to be realistic, but a lot of that sounds really ideal, and I'm very happy, actually, the way we approach maternity care in the UK. I'm very happy with the teams we work with, that if we have a problem between us, we always think about the woman, because that's sort of moves you thinking about who is the doctor, who is the pediatrician, and that kind of thing. Because if you think about the woman, then you share, all of us share the same thing. We want the best for the woman or the baby. So that's really important. But as I said earlier, if there is economical or political challenges, every time the government changes, they want to put another rubber stamp on new policy, and they also want to make that they sound like they're taking something new. And birth centers often suffer. Birth centers are closed, and the midwives are moved from the community to work in an obstetrics unit. And sometimes, women, they don't actually think about normality. We have an issue about women coming in and saying, I would like a cesarean section. That's it. I would like a cesarean section on this month, that day. And it's a lot of work you have to go through to actually discuss why they would like that. Of course, I'm going to fly the flag and say, ASEAN is a professional organization. We will be continuing working with the multiple stakeholders, and we will be doing this to ensure that all these choices that are currently in the UK will remain there for the women. Thank you very much.